Nowadays, the definition age group is much lesser, like less than 9 months also. If you see American Academy of Pediatrics, it says 2 years, whereas the European says it's less than 12 months. So in our cohort, we will take anything less than 12 months, 9 to 12 months. Any young infant who is presenting with first episode of wheezing, with examination findings of respiratory viral infection, with no other explanation of wheezing, like no other cause of pneumonia or atopy. So this is the definition of bronchiolitis. So initially they will all start with a viral prodrome, like start with cough, coryza. So following which they will develop this fast breathing, retractions, wheezing, poor feeding, which may later worsen. So as we all know, this is the pathogenesis of RSV bronchiolitis. The child inhales the viruses. So after that, the spread of infection from nasopharynx to the lower respiratory tract will happen, and following which there will be abnormal sloughing of the epithelial cells, which, as Nazgat said, they can have intraluminal obstruction and air trapping, which can lead to hyperinflation or atelectasis. So this is the common thing which we know. But what recently, this is a paper which was published in 2021. So they have looked into the respiratory mechanics. If we look into any child whom we are ventilating, so there are two components. One is the resistance component, the other one is the elastic component. So resistance is the main thing. If you look into the definition of the bronchiolitis, you all assume that, okay, there is some narrowing is happening, so we have to overcome the resistance. But what they have identified is the predominant main determinant of the work which was imposed on the mechanical ventilation. I'm talking about the cohort of the children who are intubated, like severe bronchiolitis. In that, more common is the elastic component of the respiratory system. That is like distal lung units and the chest wall, and not the airway resistance predominantly. So almost 3/4 of the total workload is generated to overcome this elastic component. So that's why if you see any bronchiolitis intubated in ICU, we may have to give higher pressures and we may have to ventilate like ARDS. So it's an equally an alveolar disease, bronchiolitis. So we will see some case scenarios like, so this is a 3-month-old male infant presented with cough, coryza for 2 days, followed by increased respiratory rate. There was no poor feeding, lethargy or fever. Previously well child, normal antenatal and perinatal period, there was no cyanosis. On examination, you noted respiratory rate between 60 to 70. There's some subcostal retractions are there. The decreased air entry, saturation 92% on room air. What might be the etiology and what do you want to do? Okay. We will come to this. So this is the child, you can see. So there was no poor feeding, no lethargy, no danger signs. Child is just tachypnic. Okay. So what might be the etiology? Actually, this is the paper published from our unit pre-COVID era. For 1 year, we looked into the bronchiolitis who got admitted. So if you see the predominant cohort of the virus, etiology is RSV, followed by the rhinovirus and influenza, para-influenza and human metapneumovirus. So this is in our cohort, common virus which we see. So the differential diagnosis, one thing we have to differentiate is viral pneumonia. Okay, viral pneumonia, they can have high-grade fever for the first 3-4 days. They can have persistent focal crackles and grunting. Or it can be viral-induced wheeze, which with background of family history of atopy and all, you can consider. And pertussis, that's also common, but they will have paroxysmal cough. Okay. So these are some of the differential diagnoses you can keep. And regarding X-ray, Satish, you want to do X-ray in bronchiolitis? No, and when you want to do, if you want to do an X-ray. There is any associated like co-infection, okay, or if it is severe type, okay, child requires intensive care, okay. So ideally in bronchiolitis, chest X-ray is not routinely required. If you have done an X-ray, what you will see usually hyperinflation or atelectasis or peribronchial thickening. Okay. It can mimic pneumonia and it should not be a determinant to start antibiotics. And you can consider X-ray in case of severe bronchiolitis who needs intensive care therapies. You can get a POCUS also done, which may not show anything, like it may show like A lines with lung sliding. So CBC usually not routinely required. Blood culture definitely no. Okay, unless you're suspecting some secondary infection or child stayed on the outside hospital and referred here after staying for 3-4 days, persistent high-grade fever, then you can consider. Virological testing, mainly to identify what type of the virus and for cohorting. Blood gas, again, if it is severe bronchiolitis. And electrolytes are not needed. So CBC and electrolytes no, and blood culture definitely no need. For if this, the index case, no need of blood culture and all these tests. So, have you guys used this? RDA score? So it contains of 4 components. You will look into the child's respiratory rate. How is the respiratory rate? Okay, is it less than 40 or 40 to 60, 60 to 70 or more than 70? And whether use of accessory muscles is there. What is the color of the baby? And auscultatory findings. Okay. Depending on that, you will classify whether it's mild, moderate, and severe. So in our index case, how much it will be approximately? You can see respiratory rate is around 70 with intercostal muscle recessions. There is color is no cyanosis. There is decreased air entry. There is no rhonchi. So it will be around 4. Okay, so 0 to 4 will come to mild. So as Samir was saying, in this case, if any child comes like this, what do you want to do? About nebulization. So what is the role of nebulization, especially in OPD basis? Like this type of mild cases, any role? What nebulization you will give? 3% saline and salbutamol. Okay. Okay, we will look into the literature, what the literature says. Okay, why do you want to give salbutamol? Because it's a increased airway resistance to decrease that. But you know the pathophysiology, right? It's mainly due to the inflammation, edema. That's why the bronchioles are getting narrowed rather than the resistance of the muscles like you will see in the asthma or in reactive airway disease the later. So use of salbutamol, whatever the studies they have done, it's not much indicated, especially not needed in bronchiolitis, especially in less than 1 year old. Okay. So epinephrine, what is the role? How it will help? Adrenaline in bronchiolitis, adrenaline nebulization. What adrenaline will do, basically? Reduce the inflammation. It will constrict the vessels so that there will be decrease in the edema. Okay, so there is a Cochrane multi-analysis which included 19 studies. So they compared giving adrenaline nebulization versus placebo to see whether it is decreasing the rates of admission. So they have noticed that by giving adrenaline nebulization, especially when the child presented on day 1, on day 2, there is definitely, it decreases the hospital admission. Okay, so, but in the later stages, like as if child presents on day 5 or day 6, the role of adrenaline nebulization is still debatable. But if they present early to you, in mild phenotype, definitely adrenaline nebulization you can give. How much dose? Dev? Okay. So usually 0.5 ml per kg undiluted, 1 in 1000. Okay. So they have noticed significant reduction in admissions at day 1. And hypertonic saline, again, it reduces the mucosal edema, it reduces the mucosal viscosity, and it enhances the mucociliary clearance. But adverse effect is it can cause bronchospasm. Again, there is a Cochrane review looked into the comparison of hypertonic saline versus normal saline. And the outcome is rate of hospitalization. If you look into this, the final effect, it favors the hypertonic saline. So this I am talking about the index case, like mild bronchiolitis, who you see in like OPD. Okay, so those are not having any danger signs. Okay. In this type of children who doesn't require admission, you think you can try nebulization, adrenaline and 3% saline nebulization, and you can monitor the RDAA score. How is it prior to giving nebulization, and after giving nebulization, how is it? So that you will know objectively whether it's improving or not. So this is the another scenario. You can see this is another 3 months old male infant who started to have cough coryza for 2 days, followed by tachypnea. There was danger signs are present, poor feeding, lethargy, fever. And if you look into the antenatal history, born at 32-week, birth weight of 1.5 kgs, no cyanosis on examination, respiratory rate 70 per minute, subcostal, intercostal retraction, decreased air entry, wheeze, saturation 88% on room air. So what do you think are the risk factors in this child? Satish? Prematurity, low birth weight. Yeah. What are the other risk factors you will see? You will look for any child with bronchiolitis. In the history, you will ask. Not in this case. In case any child comes with bronchiolitis, if you want to ask in history, what are the risk factors you want to ask? Anyone else? Mm-hmm. Good. Okay. Yes, very good. Yeah. And would you consider admission in this child? Yeah. So risk factors, as Nasakat already mentioned, whether the child is having any history of chronic lung disease, of prematurity, hemodynamically significant congenital heart disease, immunodeficiency, age less than 2 to 3 months, prematurity, or any anatomical defect of airways. So these are the risk factors you should ask in the history. And when to admit, the child is having severe respiratory distress, as in the index case, with lethargy. Sometimes they can have apnea and persistent desaturation. So that is like saturation less than 90% for more than 6 weeker and less than 92% for less than 6 weeker, and inadequate oral intake, risk factors as we have seen previously, and if there is some social circumstances. So you have admitted this child. How you will monitor? Pranav? What all things you will monitor in this child? Do you monitor saturation? Suppose this child, you have started on oxygen, saturation was 85, 86. Otherwise, child is improving. What do you want to do? Do you go by that number or? Okay. So what you will see is you will go clinically, mainly in bronchiolitis, because they can have intermittent hypoxia. Okay. That can be common in stable children, and they have done study comparing continuous pulse oximetry versus intermittent pulse oximetry, like monitoring. It will be difficult to have continuous pulse oximetry monitoring for all the children. So what they have identified is whether you do continuous pulse oximetry monitoring or intermittent, the mean length of stay and the escalation of the care and the duration of supplemental oxygen use did not differ between the two groups. Okay, especially in resource limited settings. So intermittent you can monitor. And various clinical scores. As we mentioned, one of the score is RDAA score is there. And you have to document it and you have to see it. And not single measurement, you have to do repetitive measurements to see what is the trend of it. Okay, whether it's improving or decreasing. And the role of hydration, mainly these children can have small nostrils, nose can get blocked. Because of that, they can have tachypnea, feeding difficulty. Again, it further leads to dehydration, sick children, SAADH. So what type of hydration we will prefer? Nasogastric or IV? Anyone? So again, there is one study which compared nasogastric hydration versus IV hydration. If you see the length of the stay and ICU admissions, there was not much of difference between the two cohorts. So if you think child is mild to moderate, you can start on nasogastric feeds unless it's not severe. Okay, so it's mild to moderate, you can start on nasogastric feeds and you can start. And regarding nasal suctioning, it has both pros and cons. So by clearing the nase, you are improving the work of breathing and feeding, and at the same time, it will irritate the mucosa and it can result in edema. So what they don't want to do is deep suctioning and infrequent suctioning. Okay, if you do deep suctioning and infrequent suctioning, the studies have shown it is associated with increased length of the stay. And SpO2 might increase after suctioning. So mainly it's only the upper airway suctioning is the preferred one, especially in the children with respiratory distress and feeding difficulty. And regarding the role of chest physiotherapy, so there is a Cochrane review which showed there is no evidence of benefit with any type of chest physiotherapy in length of stay, on improvement of oxygenation, or in respiratory parameters in absence of comorbidities. This is about nasal suction and chest physio. So what respiratory support we have in our setting? Achyuta? Okay, very good. So supplemental oxygen, CPAP, HFNC, non-invasive positive pressure ventilation. So in our study, which I quoted earlier, so if you see about 173 children, common mode which we used is nasal CPAP, almost 50% of the children, and HFNC in about 15%, and mechanically ventilated almost 24% in our cohort. So supplemental oxygen, yes, hypoxic infants in non-threatening manner can be given free flow oxygen, face mask or nasal cannula, and oxygen should be discontinued if saturation is around 90 to 92%, and mainly clinically you have to see how is the child's respiratory distress, work of breathing. HHFNC, what are the advantages? Just a brief on that. Anyone? Okay. So there is a mnemonic you guys can remember, high flow. Okay. H stands for heated and humidified, means it provides heated and humidified gas. I is inspiratory demands, means it can better meet your peak inspiratory flow demands. F is it increases FRC, functional residual capacity. And L is it is lighter. If you compare to CPAP or BiPAP machine, this machine is lighter. And oxygen dilution, it minimizes the oxygen dilution and wash out the dead space or decrease the work of breathing. Okay. So this is the thing. And CPAP will, again, it will give some amount of PEEP so that it will help to open your bronchioles so that it will decrease the airway resistance, air trapping and hyperinflation. So how much you will start with? If you want to start HFNC, how much flow you will start with ideally? 2 liter per kg per minute. So that's the usual thing, 2 liter per kg per minute. Studies have compared with 3 liter per kg also, but in that cohort, they have more discomfort with a similar failure rate compared to 2 liter per kg. So you can start anywhere between 2.5 to 2, and you can start with 2, monitor, and then slowly you can wean. And CPAP. So whatever the CPAP they are describing is, it's not an indigenous CPAP. What they have is which is a company made FNP, Fisher and Paykel CPAP, which is what we use is different. What we use is indigenous. So we can't compare our CPAP with theirs. So that we have to, because all the studies they have done with a CPAP which is proven effective. So in this we are still in the learning phase. So when the child is on HFNC, you will monitor what all things you will monitor. Again, the same thing. RDA score you will monitor, respiratory rate you will monitor, how is the work of breathing you will monitor. All the things you will monitor. If it's worsening, then you may have to consider intubation. Like child is having severe respiratory distress, child is lethargic, child is having seizures, apnea. So in those conditions, you have to intubate the child. Or cardiovascular signs of hypoxia, like marked tachycardia, bradycardia, or hypotension. So these are the indications where you will intubate the child. So this is a trial, RCT, comparing high flow with nasal oxygen. So oxygen therapy. So you can see here the escalation of care in the high flow group is 12%, whereas in the standard therapy is 23%. Okay, definitely it says that high flow can be used as a rescue therapy. So use of high flow should be reserved for escalation of therapy if standard subnasal oxygen fails. And HFNC versus CPAP. Again, I'm telling this CPAP, they used is different to what we use. So in this, if you see, the nasal CPAP group, patients with at least one failure is only 31%, whereas in the HFNC group, it is 50%. So you can see CPAP can be considered in severe bronchiolitis. So what about in our cohort? So there is one study especially looked into our bubble CPAP, which is indigenously made, versus high flow nasal cannula in children with pneumonia. In this, what the results have shown, it's actually an unpublished data. So you can see the infants with acute bronchiolitis, which is the cohort which we are discussing, they fared better on HFNC as compared to nasal, this bubble CPAP. So you can see 23% they have escalation, they have improved here. Whereas compared to HFNC, it's only 5% needed escalation of care, whereas bubble CPAP 23% needed escalation of care. So children on HFNC showed faster resolution on respiratory distress. So the guideline says any child admitted to the hospital, first you will see how is the child, infant, whether it's mild, moderate. Is the child hypoxemic? Yes, if hypoxemic, start on low flow oxygen. If the infant respond, you will titrate and wean. No, child is not responding on low flow, you have to escalate to high flow nasal cannula, 2 liter per kg per minute, titrate the FiO2. If the infant responds, okay, you can titrate the FiO2. Once stable, you will wean the flow and all. But if it's not responding, you have to escalate the care and consider CPAP. So in our setting, in the emergency, you will start with low flow oxygen. If the infant responds, you will wean. If it's not child is not responding, if you have HFNC, you can start that. If you don't have, you may have to go for CPAP. So response to therapy, you can look into the how is the heart rate, respiratory rate, early warning scores. For infants less than 6 months, all the guidelines say CPAP seems superior to HFNC. So hypertonic saline, this we are discussing in inpatients. Like inpatients, also there is a Cochrane review which compared hypertonic saline versus normal saline. And you can see it helps in decreasing the clinical severity scores and decreasing the risk of hospitalization in outpatients. So, and all the guidelines says it should not be used like continuously. You have to look for the response. Okay, you give once 3% saline nebulization and look for the response. If there is improvement, well and good. If next time again, if needed, you can give. Okay, it's not like Q6th early or Q4th early, you will chart and leave it. And what is the dose? You will start ideally 3% saline nebulization. 3 ml, 3 to 4 ml. So our protocol says 4 ml. Okay. With adrenaline nebulization, we will give and see. So we can consider in inpatients, but not like Q6th early, Q4th early. You will give one dose, see for the response. If the response is there, then if next time if it requires, you can try again. Okay, it's not like you. And epinephrine also in inpatients, you can see significantly there is a shorter length of stay compared to salbutamol. And there is one large RCT which I will discuss later, which compared adrenaline nebulization and dexamethasone combined versus placebo. So they have showed shorter admission rate at day 7. So it can be used as a rescue measure, epinephrine, in critical cases. And bronchodilator, coming to this, there are so many meta-analyses in inpatient cohort and outpatient cohort, but there is very high inconsistency if you look into it. inpatient and outpatient, very high inconsistency between the 21 studies, and the overall summary effect was significant, they have told. But there is no role in first episode in all the guidelines. So there is no role of salbutamol nebulization. So what nebulization we have used in our cohort, if you see among 173 children, 3% saline nebulization was given to almost 66% of the children, and epinephrine for 15%. 3% saline with epinephrine combination was given for about 12% of the cohort of children. So this is the next case. So this is a 4-month-old male infant, started with cough, coryza. Similar scenario, you started the child on HFNC 2 liter per kg per minute. But he was tachypneic with worsening sensorium. So you have intubated the child. So what are the ventilation strategies in bronchiolitis? Do you ventilate like asthma child? Like giving lower rates, prolonged expiration? Okay. So the same thing which I discussed in the initially, that elastic component, which is having the predominant thing. So means mainly the lower airways, alveoli. As we discussed bronchiolitis, it's equally an alveolar pathology. So if you do at the bedside, sometimes we may have to give higher PEEP, okay, because it will act like ARDS. We have to follow the ARDS strategies. Okay, optimum PEEP we may have to give to achieve the adequate oxygenation. Definitely, sometimes higher PEEP, delta P we may have to give to overcome the resistance. That we have to see bedside, how is the tidal volume and how is the compliance and resistance. But PEEP also, optimum PEEP we have to give. Sometimes we may have to give up, not ending like asthma 3-4 PEEP. We may have to give up 8 PEEP also sometimes in the small infants. And as we said, adequate oxygenation. So permissive hypercapnia, yes, they can have high CO2s, but till your pH is more than 7.15 or 2, you can accept that. And oxygenation. So PaO2 anywhere between 60 to 90 is acceptable. And good pseudoanalgesia. So these are the things which you try to manage in sick child. And role of steroids, either dexamethasone, hydrocortisone, anything, any role. So again, the Cochrane review, which says 17 trials, which showed no effect of systemic steroids, whether it's oral, intramuscular or IV, in the hospital admission rate or length stay or clinical score after 12 hours or readmission rate. And there is no effect of inhaled corticosteroids during acute phase of bronchiolitis or in prevention of recurrent wheezing following bronchiolitis. So there is a recent multi-center RCT which was done in Australia and New Zealand, DAB trial, which included 210 children with bronchiolitis, where they have used systemic corticosteroids with nebulized epinephrine versus placebo. The outcome they looked is duration of positive pressure respiratory support, and they have seen that 26 hours in the intervention group versus 40 hours in the control group. So this is the recent study. So, but routine use of steroids currently is not recommended. So it's still, there are some studies, because the problem in bronchiolitis is there are various studies, but the outcome measures are not same. There are very inconsistency. Some measure this positive pressure respiratory support, some measure the duration of hospital stay, some measures the clinical scores. So there is very inconsistency on that. So as of now, the role of steroids currently not recommended in infants with bronchiolitis. Antibiotics. Abhirami, you want to start antibiotics? If you want to start, what antibiotic and to cover what organisms? Okay. So in children with bronchiolitis in the OPD, risk of secondary bacterial infection is very low. So therefore there is no indication for routine use of bronchiolitis in antibiotics. Whereas severe bronchiolitis requiring mechanical ventilation, in those cohort also there is 37.7% risk of bacterial co-infection with H. influenzae, strep pneumoniae, moraxella and staph aureus. So these are the common organisms identified. So to cover that, in the sick cohort of children, you can give antibiotics like ceftriaxone. Sometimes we may give clox also. But there is no role of any antiviral therapy. Complications, you can see in our cohort, almost 44 children has complications. That's about 25% of the children. And the predominant is encephalopathy, followed by transaminitis and shock, hemodynamic instability. So as we mentioned, they can have ARDS, they can develop later bronchiolitis obliterans, asthma, and if it's a viral predome, they can have associated myocarditis and arrhythmias. So this is the study which I quoted. You can see IV fluid use is only 50% of the children who are admitted with bronchiolitis had needed IV fluid. Antibiotic in 35% of the children. Steroids, maybe in sick cohort with ARDS, they might have started 11%. Vasoactive agents, IVIG. IVIG might be child having associated viral myocarditis. And duration of PICU stay is median is around 3 days, whereas the interquartile range between 2 to 6 days, and hospital stay is 5 days, and mortality is around 8%. So, criteria for discharge, when they are clinically stable, they're taking adequate oral fluids and maintain saturation in the air at the following levels for 4 hours. Like if it's more than 6 weeker, more than 90% is okay. If it's less than 6 weeker, more than 92%. Red flag symptoms which you have to tell all the parents at the time of discharge. If the child is having increased work of breathing, or there is a decrease in the fluid intake, if the child is having apnea or cyanosis, or child is feeling exhausted. So these are the red flag symptoms you have to tell the parents. The prevention, breastfeeding, hand hygiene, and avoid passive smoking and immunoprophylaxis. Immunoprophylaxis, one slide, anyone? Which cohort of the children it showed effective? Apurva? All infants or any specific cohort? There? Okay. We will look into the guidelines what it says. So what we give is palivizumab. So the cohort which they have shown effective is if any preterm infant born less than 29 weeker, okay, they have to receive RSV prophylaxis maximum 5 monthly doses or until the end of RSV season. Okay. And these are the cohort of the children preterms without having chronic lung disease. If they have chronic lung disease less than 32 weeker with chronic lung disease, they should get RSV prophylaxis. And infants born with congenital heart disease with acyanotic heart disease, we should give 5 monthly doses. So these are the 3 cohort of children, less than 29 weeker without chronic lung disease, and less than 32 weeker with chronic lung disease and acyanotic disease. So these are the 3 cohort of children where you can give palivizumab. So this is our protocol. You can see first is to identify a child with bronchiolitis. So initial stabilization is very important, like providing position of comfort, place child in parent's lap, start humidified oxygen to maintain SpO2 more than 92%, IV fluids if required. Then you will assess for severity by using RDIA score. Okay. When you will intubate, that also we discussed, like if child is having severe respiratory distress, altered sensorium, okay, restlessness, all these things, when you will immediately intubate. So once you have done an RDIA score, you know whether it's a mild, moderate or severe. If it's mild, like in the first scenario which we have seen, you can try nebulization on OPD basis, like 4 ml of 3% saline nebulization once with adrenaline 0.5 ml per kg of 1 in 1000. You have to see for the response. Okay. If there is good response, you can observe for 12 hours and then you can send them. Moderate, that is anything between 5 to 8 score. So saturation less than 92%, you can consider oxygen, supplemental oxygen. If child is not improving, you can escalate to high flow nasal cannula or CPAP. And you can try the nebulization. Again, you have to see for the response. Okay. Not routinely you will give. And severe, you will start again with high flow nasal cannula and you will see for the response. It's improved, you will continue respiratory support and monitoring. If it's not improved, you will escalate further and look for further diagnosis. If needed intubation, you will intubate. So this is our ER protocol for bronchiolitis. So the final take-home message, bronchiolitis, remember it's equally an alveolar pathology. The importance of clinical severity scores, role of nebulization, the OPD and IPD, and what type of respiratory support to use in bronchiolitis and ventilation strategies in bronchiolitis.